So maybe, Della, maybe you could tell us briefly about the TaylorX project. Well, actually, let me back up and ask you, like, because this is a very historical project, and I'm sort of curious for you what the contrast is like compared to when you started in treating cancer. Back then, how much was there, like trying to figure out what particular kind of cancer a patient had versus now?
Well, so I think that there's been a lot of changes from when I started taking care of patients with breast cancer until now. And as far as figuring out what kind of cancer a patient had, there are a few sort of classic prognostic markers that we look for in breast cancer: hormone receptor status, HER2 status, tumor grade, which is basically how aggressive a tumor looks under the microscope, and then also we think about the anatomic stage, how far the cancer has progressed in the body. That was sort of all we had when I first started taking care of patients. And there were randomized studies looking at adding chemotherapy to patients with early breast cancer that showed that chemotherapy added some benefit as far as curing patients with early breast cancer and eradicating what's called micrometastatic disease. But we knew that, especially for women who have the hormone receptor positive subtype of breast cancer, we were overtreating a significant proportion of women. But what we didn't have was the tools back then to actually be able to tell someone up front if the chemotherapy would benefit them.
So it was just chemotherapy for everybody?
So it was pretty much chemotherapy for everyone who agreed to it based on stage of disease and their general health and their age. So patients would say to me, is this going to work for me? And how do you know if this is going to help me? And I would have to say to them, there's really no way to tell. All I can tell you is the results of the studies that we have, that if we take a large number of women with your stage of cancer and we give half of them chemotherapy and we don't give the other half chemotherapy, we cure more women who have gotten the chemotherapy. And then the next real advance was the advent of multi-parameter gene testing, and what those are, they're tests that look at gene expression in tumor tissue.
So that means which genes are turned on?
Yeah, basically which genes are turned on, which of them are transcribing RNA and making proteins, and there are a variety of these tests that are commercially available. And they can subdivide cancers, and we can learn more about the biologic behavior of that particular breast cancer by looking at those tests. And they generate a type of a signature that can be used to tell us information about prognosis and can also be used to tell us information about benefit from chemotherapy. And one of these multi-parameter gene tests is a test called the Oncotype, which looks at 21 genes, 16 cancer-related, 5 reference genes, and measures their expression by RT-PCR.
Which is what?
Reverse transcriptase polymerase chain reaction.
Okay.
So basically what I do as a clinician is ask the patient, tell the patient about the test, ask if they would be interested in having this test run, and then send a piece of their tumor to a lab that runs the test on, and it comes back with a recurrence score, which is a number that goes from 0 to 100 and is both prognostic and also predictive of chemotherapy benefit. So for patients who have a low recurrence score, what we know is they have a very good prognosis. If I give a woman with a low recurrence score chemotherapy, I don't make her good prognosis better. I just give her side effects. Then there are women with high recurrence scores those women have a more aggressive type of cancer and they have a poorer prognosis, but those are the women who are really impacted positively by chemotherapy. Those are the women whose lives are saved by chemotherapy. And there were a group in the middle that really constituted the majority of patients with hormone receptor positive early breast cancer that we didn't really know what to do with. And so and what I would get back from when I would talk to my patients would be a piece of paper with their score on it, with the graph, and with where they fit in on the graph, and where, how patients like those would have fared in, sort of retrospective studies when looking at tumor specimens when they got chemotherapy. So the TAILOR-X study basically was a randomized trial of over 10,000 women, where women with early node-negative, hormone receptor positive, HER2-negative breast cancer agreed to have this test done on them. They got the recurrence score back, and then they were asked to, if they wanted to continue on with the study. Women who had a low recurrence score of 0 to 10 automatically did not get chemotherapy. Women who had a higher recurrence score of 26 and up automatically did get chemotherapy. And then the women who were in between were randomized to get chemotherapy or not chemotherapy. And all the women got surgery and hormonal therapy and the other standard of care treatments. And those women were followed for several years. And earlier this month, the results for the randomized group were presented and published. And they showed that the majority of women who had a intermediate range recurrence score did not benefit from chemotherapy.